It's frequently surprising that patients present with widened anion gap metabolic acidosis, and bedside clinicians don't even think of the possibility of ketoacidosis because the patient's not a diabetic. Ketoacidosis is much more common than you might imagine in your clinical practice. The reason why you're not seeing it is because you're not measuring ketones, and frequently the dipsticks are negative when the patient has positive blood ketones. In this particular tutorial, I'm going to talk about two specific types of ketoacidosis, that associated with alcoholism on the one hand and starvation on the other. There's a fair amount of overlap between the two, but as I will explain, there are differences that you need to be aware of. Join me and I guarantee you'll learn something. Ketoacidosis, Part 2. This tutorial is on the topic of alcohol and starvation ketoacidosis. In the previous tutorial, I introduced ketoacidosis and discussed the metabolism of carbohydrates and fats and how ketones are produced and metabolized. I explained that when you come across a patient with ketoacidosis, this reflects broad metabolic failure. The most frequently observed version of ketoacidosis is what we see in acute severe diabetes, so-called diabetic ketoacidosis, and I explained that this is a very precisely defined syndrome and that not all ketoacidosis that you see in diabetics fits the paradigm of diabetic ketoacidosis. That paradigm results in management guidelines that are produced by international organizations for the management of that disease itself, but not necessarily for all cases of ketoacidosis in diabetic patients. This particular tutorial looks at ketone production and alcohol, and why patients who are heavy drinkers or patients who are malnourished or starved for a period of time develop ketoacidosis. I subsequently discussed the treatment of these forms of ketoacidosis and the potential complications. Let's start with a clinical scenario. You're called to the surgical ward to see Jude. Jude is 36 years old. He presented to the ED with abdominal pain and has mild abdominal tenderness and nothing else. Jude is underweight, likely has an eating disorder, and has mild peripheral edema. On examination, Jude is fecal occult blood positive. The labs are as follows: sodium 125, potassium 4, chloride 98, glucose 4.2 millimoles per litre. LFTs are normal and the albumin is 25 grams. So that's a normal glucose with a low albumin, low sodium and low chloride. The chest x-ray is clear. He was started on lactated ringers or Hartmann solution at 100 ml an hour and given an intravenous proton pump inhibitor and then sent to the ward. Now that was on Friday. On Monday morning we were called to see him. Jude is now progressively distressed, tachypnic, tachycardic and hypotensive. There are no clear physical signs. The urinary catheter bag is full, so Jude has good urinary output. The labs are as follows: sodium 120, potassium is now high 6, chloride is 100, the phosphorus is 0.5, which is low, and the glucose is now 10 or 180 grams per deciliter. Hemoglobin is 7, the amylase and the LFTs are slightly raised. On the blood gas analysis, the pH is 7.16, the PaCO2 is 17.5 millimeters of mercury or 2.3 kilopascals. The bicarbonate is very low, 6.2, with a base deficit of 20.6. The lactate is 5.5 and the anion gap is 42. The surgical team want to take Jude to the OR, believing that he has a perforated duodenum. There's clear evidence of acute stress, there is a low hemoglobin and a lactic acidosis, all in favour of this diagnosis. However, before they do anything, one test needs to be performed before anything happens, and that test is a blood pinprick test to measure ketones. The initial ketone measurement was high, but when we first got an accurate measurement, it was 7.8 millimoles per litre. Urinary ketones were +3. So Jude has starvation ketoacidosis, associated with large volume aquaresis, associated with administration of isotonic resuscitation fluid. Now, I covered this in one of my tutorials on hyponatremia, and you can find that at my YouTube channel or at my blog. Although there is abdominal pain and he may well have a bleeding ulcer, ketoacidosis is the current problem and it needs to be resolved. Simultaneously, you're called to the ED to see Wanda. And Wanda is a 40-year-old female who is acutely short of breath. Her GCS was 15 when she came in, tachypnic, tachycardic, hypertensive. Her saturation is 98% on 28% oxygen. The ECG was normal, chest x-ray clear, and this is her blood gas. And you can see that Wanda has a metabolic acidosis characterized by a low pH, a low PaCO2, and a low bicarbonate. The base deficit is 26.6. You'll note that there is a lactic acidosis. The lactate is 5.6. There's also ketoacidosis. The ketones are 8 millimoles per liter, and there is likely also a mild renal acidosis with an elevated plasma creatinine of 145 millimoles per liter or 1.5 milligrams per deciliter. Now, this would be very easy to characterize as acute diabetic ketoacidosis, but here is the nub. Wanda is not and never has been a diabetic, and that can be confirmed by checking the HbA1c, which we did, of course, but that came later. Exploring Wanda's background, it turns out that she has been abusing alcohol for some time, 12 to 20 units per day. However, there was no alcohol consumption within 30 hours of admission, and simultaneously, Wanda has been on a calorie-restricted diet for 3 weeks and hasn't eaten for 4 days. So what we have here is the classic picture of alcoholic ketoacidosis. Let's move on to a discussion about the metabolism of alcohol. In this cartoon, I have a picture of the liver, and on the bottom right-hand corner, there's a cell. Alcohol, as we understand it, is ethanol, and ethanol is metabolized by the liver initially into acetaldehyde, then into acetate. Then acetate leaves the liver and goes to cells where it's ultimately converted into acetyl coenzyme A. Ethanol is a curious chemical because it actually suppresses the metabolism of dietary fats into free fatty acids. It's metabolized, as I mentioned, into acetate, and acetate is transported into cells via a monocarboxylate transporter. It is there compounded into acetyl coenzyme A and undergoes oxidative metabolism. Although alcohol does not impact glycolysis per se, it may impair gluconeogenesis and certainly interferes with the beta-hydroxylation of fats into free fatty acids. As a consequence, patients do not develop ketoacidosis if they are actively drinking. It is important to note that neither acetate, acetyl coenzyme A, nor free fatty acids can be used to manufacture glucose by gluconeogenesis. So in the situation like Wanda, where we combine alcohol and starvation, we have the metabolism of muscular protein into amino acids. Glycogen and gluconeogenesis will generate glucose that is subsequently metabolized to lactate and pyruvate and subsequently oxaloacetate. Glycogenic amino acids are also broken down, sent to the liver to regenerate glucose by gluconeogenesis. And this is really important because that's how we keep the blood glucose level high enough in the body to ensure that obligate glucose using organs such as red cells have sufficient glucose present to keep functioning. During all of this, the alcohol is providing most of the substrate for energy, converted to acetate and then to acetyl coenzyme A. The clinical history of patients who present with alcoholic ketoacidosis appears to follow a classic picture. There's chronic alcohol abuse with abrupt cessation. Alcohol normally suppresses ketone production. There is persistent hypoinsulinemia that we associate with starvation. So when the alcohol stops, there is uncontrolled release of free fatty acids and ketogenesis. Frequently, the patient would also be hypovolemic because they've stopped drinking liquids. Let's look at those processes. So we have muscular protein that's broken down into amino acids and adipose tissue broken down to free fatty acids. And once insulin has been discontinued and insulin levels remain low, there is rapid breakdown of both fat and muscular protein. Protein breakdown may be glycogenic to make glucose or ketogenic to make ketones. This is driven by both loss of calories derived from alcohol and disinhibition of fatty acid breakdown due to the absence of both alcohol and insulin. It appears to me that in malnutrition, whether it's alcohol related or not, the islet cells atrophy or at least hibernate, and there is relative hypoinsulinemia to control the dysmetabolic state. As a consequence of all of this, there is dysglycemia. The glucose level may be high, it may be low, it may be normal. Normal or hyperglycemia results from gluconeogenesis, assuming that there is sufficient substrate available. Insulin levels are really low, and of course, alcohol, when it's present, reduces gluconeogenesis. That's why you sometimes see patients, for example, with acute alcohol poisoning, who have very low blood sugars. They also have very high lactate levels because there is impaired utilization of lactate to pyruvate. And so this is the picture that we see. Alcohol consumption stops. We have reduced insulin. There's a big increase in glucagon or cortisol or epinephrine, depending on what started all of this process, with impaired gluconeogenesis and hyperlactatemia with dysglycemia and lipolysis leading to ketone production. So the ethanol is now gone, and there is uncontrolled production of acetyl coenzyme A that generates acetoacetate and beta-hydroxybutyrate. Prolonged fasting results in downregulation of the anabolic response, minimal insulin secretion, and islet cell hibernation. Fat is mobilized to provide ketones for major systems. Muscle protein is mobilized to maintain euglycemia to provide substrate for obligate glucose-using cells. Of course, in this situation, a lot of what's happening is driven by the stress response and all of that circulating adrenaline. And we see a very, very similar picture that leads to a metabolic acidosis. So the patient has four problems. 1, the source of the stress response. 2, metabolic acidosis principally being driven by ketones, but there may be a lactic acidosis present as well. Relative hypoglycemia and hypoinsulinemia, and then of course the risk of the therapy, which is withdrawal syndromes for alcohol or other drugs, and refeeding syndromes, including refeeding patients with electrolytes. The patient requires glucose to restart the Krebs cycle, but usually also requires exogenous insulin to suppress free fatty acid breakdown and to move glucose into cells. Be aware that the patient is at risk for a number of refeeding syndromes and alcohol withdrawal syndrome. Let's talk about refeeding. Refeeding syndrome is seen in severely malnourished patients who are administered glucose. It's due to a rapid increase in circulating insulin, and this results in 3 phenomena. 1, the rapid movement of glucose into the cells, resulting in hypoglycemia. 2, the rapid movement of potassium, phosphorus, magnesium, and calcium, but principally potassium and phosphorus, into cells, resulting in hypokalemia and hypophosphatemia. And 3, the rapid increase in cellular osmolality causes cells to swell and rupture. So what we have here is a patient who is given glucose. This generates an insulin response that activates the transport of glucose and intracellular electrolytes to go in, increasing the osmolality with water going into the cell, and the cell then expands and swells. In extreme circumstances, the cells, particularly the muscle cells, will swell so much that they rupture, releasing intracellular content into the extracellular space. 2 moieties are of major concern here. The first is potassium. If the potassium levels rise high enough, it will destabilize cardiac conduction tissue and may lead to arrhythmias or cardiac arrest. And myoglobin, that poisons the renal tubules and causes acute kidney injury. This process is known as rhabdomyolysis, and it can result in death. So you need to be very careful when you start feeding patients and start giving them intravenous electrolytes that you don't precipitate this. You need to be watching the potassium and phosphorus levels very carefully. the levels fall very abruptly before the second phase happens. So you must keep on top of the electrolytes, make sure you give plenty of electrolytes to the patient, but not overdo it with isotonic fluids. Now let's move on and look at the treatment of alcoholic and starvation ketoacidosis. The therapeutic strategy here involves a number of things: glucose, insulin, sodium and chloride, B vitamins, nutrition, potassium and phosphorus, and sedation. They're not all given together. Normally, you will start a resuscitation with glucose, often inside a vehicle that gives the patient sodium and chloride at the same time. For example, half normal saline with 5% dextrose. That's available in every hospital in the world. Maintenolite would be a good alternative fluid that you would run at 125 mils per hour. The patient will likely need phosphorus and potassium repletion fairly aggressively and fairly early, usually 20 to 40 millimoles. If the blood glucose exceeds 8 millimoles per litre or 150 milligrams per deciliter, an insulin infusion should be started. B vitamin complex should be given to the patient at an early stage. That's a banana bag. Doesn't have to be given immediately, I'll talk about that in a minute, but needs to be given. And you should start thinking about sedation in the patient with potential alcohol withdrawal syndrome. Usually, one would give the patient a long-acting benzodiazepine, such as Librium, chlordiazepoxide, or lorazepam, and consider an intravenous infusion, for example, of dexmedetomidine. And finally, care must be given to feeding the patient because the patient will need nutrition, particularly glucose, and so one should consider starting enteral feeds or TPN and watching again the potassium and the phosphorus. Pure starvation ketoacidosis is very, 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 very tricky to deal with. You have to weigh up the risk of refeeding syndrome versus persistent auto-cannibalization. Strangely, in really severe malnutrition, the pancreas just doesn't respond. And when you give dextrose to the patient, often the blood sugar surges. And that's why those patients may need an insulin infusion. Also, because the bowel has become atrophic in someone who has not been eating for a long period of time, frequently when you give the patient enteral feeds, either a gastroparesis prevents the stomach from emptying, or else the feed just runs straight through the bowel and isn't absorbed. So I think you should consider giving TPN, total parenteral nutrition, at quite an early stage to ensure sufficient protein calories to maintain mean body mass. Care must also be given with intravenous fluids. Be extremely careful in malnourished patients, particularly alcoholics, when administering IV fluids. Be cautious at least with giving isotonic fluids. These patients don't really need so-called resuscitation fluids. And once you give all those osmoles to the patient, it may result in a rapid aquaresis. That's massive diuresis. That's movement of water into the kidneys and out into the urinary tract, because those patients have been chronically low in osmoles. They haven't been able to dilute their urine. And as a consequence of this, there can be rapid transcellular fluid movement from the intracellular to the extracellular space. So this is kind of the opposite of refeeding in terms of nutrition. It's refeeding with electrolytes, where you have water moving out of cells. And this can result in osmotic demyelination syndrome or intracranial hemorrhage. You don't have to give B complex vitamins as soon as the patient arrives in the ED, but you do need to give thiamine early, and that's due to the risk of acute Wernicke's encephalopathy characterized by confusion, ataxia, and ophthalmoplegia. Thiamine is a cofactor for the TCA or Krebs cycle, and reactivation of the cycle without thiamine may be associated with Wernicke's. But be aware, hypoglycemia is a significantly greater risk for the patient that can cause brain damage than Wernicke's. So don't delay giving glucose while you go looking for banana bag in the presses in the ED or whatever. Give the glucose and then send someone looking for the Pabernecks. On the surface, it may appear that starvation and alcoholic ketoacidosis are the same thing, but they're not. The starvation patient may have a precipitating factor, such as admission to the hospital following a car crash, a surgical problem, an assault or specific injury, pancreatitis, myocardial infarction, community-acquired pneumonia. There's medley causes for that. Some of the surgical patients may be admitted with an abdominal problem, then they're kept to nil by mouth and given resuscitation fluids as maintenance fluid, and they end up with ketoacidosis 3 or 4 days after being admitted to the hospital. Traditionally, these patients tend to be dehydrated. They have low body mass index or low lean body mass, so they don't have much reserve to call on. The albumin level will be low to normal. The electrolytes will usually be relatively normal, perhaps with a low potassium, and the glucose will be normal to high. These patients are at high risk for refeeding syndrome, particularly the patients who have chronic malnutrition. The alcoholics are a little bit different. Usually the problem is precipitated by a cessation of ethanol. Remember, cessation of ethanol means cessation of calorie intake for many of these patients. The ketoacidosis is also joined usually by a lactic acidosis. The patient will have a fatty liver on ultrasound and low lean body mass. The patients are classically hyponatremic due to potomania, so they're at high risk for the complications of the management of severe hyponatremia, particularly osmotic demyelination syndrome. Classically, they have a low blood glucose, and that will require replacement fairly early, but that may rebound to hyperglycemia. The use of isotonic fluids may also cause aquaresis. That's a large volume urinary output. These patients are at very high risk for alcohol withdrawal syndrome. So let's look at our two patients, Wanda and Jude. Wanda was an alcoholic who went on a diet, so she has a combination of alcoholic and starvation ketoacidosis. She was given half saline with dextrose and an insulin infusion. She was given Pabernex. She was given chlordiazepoxide and dexmedetomidine. And her metabolic situation resolved really quickly within 12 hours. Remember, her starvation has been relatively recently. She's been reasonably well nourished with calories from all that alcohol. So once you replenish the glucose and sort out the problem with ketones, she settled down very, very quickly. Jude may be more complicated because here we have someone who is chronically malnourished and also has ketoacidosis. In this situation, he required intravenous dextrose to reboot the Krebs cycle and his banana bag. Now, there was careful monitoring and replacement of electrolytes, and again, his blood sugar exceeded 8 millimoles per litre, so he got an insulin infusion. All of this didn't settle down that quickly. This takes a while to settle down, and it's really important that you keep on top of nutrition here because you do not want any further protein breakdown within this patient's body. But also keep in mind that there was a problem that brought Jude into the hospital. He had abdominal pain, he had fecal occult blood, and he's a low hemoglobin, so he must have a gastroscopy when metabolically stable. He should also get a blood transfusion. His hemoglobin was 7. This is not going to fix itself. He likely has bone marrow suppression from chronic malnutrition. In this case, enteral feed was commenced, but he did not tolerate it, so TPN was started at a modest level, watching for refeeding syndrome. The enteral feed was continued to hopefully bathe those enterocytes to feed them with some glutamine in order for them to restore themselves so the patient's bowels started working properly afterwards. Let's review this tutorial. In this tutorial, I looked at alcoholic and starvation ketoacidosis. One doesn't get ketoacidotic while consuming alcohol because alcohol suppresses the production of ketones. So usually the alcohol is stopped and then they become ketoacidotic. I discussed the mechanism of ketoacidosis in alcoholics and why starvation ketoacidosis was very similar, but it's not the same because that patient is chronically malnourished and they often have low protein and fat stores as compared with alcoholics who may still be malnourished, but they recover much more quickly from ketoacidosis. I discussed the treatment options and the complications of treatment, particularly refeeding and withdrawal syndromes. In the next tutorial, I'm going to discuss a very modern phenomenon known as euglycemic ketoacidosis. This is usually associated with a modern class of drugs known as sodium glucose cotransporter 2 inhibitors, SGLT2 inhibitors. We're going to look at how to diagnose it the treatment and the potential complications of treatment. I'll see you then, and I guarantee you'll learn something. So that was alcohol and starvation-associated ketoacidosis. If you found this tutorial helpful, please like me on YouTube, subscribe to my channel, make some comments and introduce me to some of your friends and colleagues. You can also follow me at ccmtutorials.org. Next time, we look at another cause of euglycemic ketoacidosis.